So let's directly go then to the first presenter, Bill O'Neill, one of the pioneers in applying EcPella in cardiogenic shock in the Henry Ford Hospital. Thank you very much for showing how you do approach this fundamental problem of unloading when using ECMO. There was an alarming message a few years ago showing that the increasing use of ECMO goes hand in hand with a decreasing survival of those patients, which may point to some lack of understanding of how we do use these pumps.
Yes.
And your ideas are certainly very important.
Thank you very much, Patrick. It's wonderful to be here this morning. And I'd like to start this part of the debate. Like Ronald Reagan, I'm not going to worry about Dirk's youth and inexperience, but I have the old wisdom of being able to sort of share some information. Very briefly, to why are we interested in this? Henry Ford Hospital is a very large transplant and VAD center. Our vascular and our cardiac surgeons and our heart failure specialists have kind of relied on balloon pump and ECMO. And EcPella has been a little bit of an outsider that we primarily use in protected PCI. In addition, as a major transplant center, we get referrals for patients with acute flail leaflets, with acute LV dysfunction, and in particular, recently we've had a rash of patients with bioprosthetic, aortic bioprosthetic valve failure that develop a sudden acute massive wide open AI. And those patients have been difficult to support with the tools we have. So my colleague, Dr. Pedro Villablanca, and Marvin Eng initially 5 years ago started looking at this concept of left atrial venous arterial ECMO, otherwise known as LAVA. In fact, Pedro's name now is Pedro Lavablanca because he's always in the cath lab looking for a patient. And so it does take youth and passion to sort of drive these processes. So we know that with increasing ECMO use, there has been a decrease in survival, and I think it's really basically that we're using more and more, and on the sickest of the sick patients. Now there are methods of being able to reduce the ECMO unloading or unload the ECMO either with inotropes, with a balloon pump, which is frequently done, surgical venting, and PA catheter drainage. And so now we've got this new method of being able to unload the ventricle. And you can see that in comparison with ECMO and EcPella, we're able to really significantly decrease LV pressure and volume. And this is actually Dr. Hunziker's work. So it's associated with biventricular improvement in LV function. And so we'd like to demonstrate to you exactly what the details are for VA-ECMO. And again, you can see that what happens with just regular ECMO, you have an increase in afterload and a marked increase in left ventricular end diastolic pressure. And so therefore, you're going to have difficulty with increasing in LV distension. So how can you do this? How can you decrease pressures and in a way that really prevents pulmonary edema? And so these are the ways that we can distend. Inotropes have a modest effect. Balloon pumps probably negligible effect. And so then using EcPella, I think, has now been the standard. So people are using this EcPella combination quite a bit. And it's very effective, and I think that we're going to hear more and more about that, and the LV unload study obviously is going to be the science to demonstrate that. Well, there is an alternative, and this is the LV LAVA ECMO circuit. You can see on the bottom that the cannula actually has a number of side ports, and by putting this across the septum, you can actually have a lot of the blood drain from the left atrium and from the right ventricle. So you have an admix of arterial and venous blood that goes into the oxygenator and then gets reimplanted into the femoral artery. So that's basically how the circuit is done. The only thing different from this than regular ECMO is that you have a catheter across the LA, which is draining the left atrium and thus draining the left ventricle. You can actually demonstrate color flow on the left side from the right into the right atrium from the left ventricle. The way that this is done is with ICE guidance that you can do transeptal puncture and then we use a balloon, an Armada balloon, to dilate the septum, and then over that Armada balloon you can actually just advance the ECMO cannula. And it's the only difficulty that's involved is the use of the ICE catheter. At our institution, we have a huge number of people because of our large structural heart program that are very facile and competent in using ICE guidance to do the transeptal puncture. So we looked at Henry Ford. In our registry, there were 25 patients that were successfully treated, and we have data that now has been analyzed. Basically, in the bottom, you can see that the large majority of these patients were in cardiogenic shock. Many of these patients had a severe severe aortic insufficiency. Many had severe mitral insufficiency, and some had ventricular septal defects. And these are the results. So we looked at these carefully. The right atrial pressure drops. The mean pulmonary artery pressure drops. The blood pressure doesn't really change very much, and the heart rate doesn't change very much. So this really kind of helps show that the LV energetics are substantially improved with this device. But probably more importantly, the cardiac index significantly increases. The cardiac power goes from 0.6, which is in a shock state, to over 1.4. And then the pulmonary pulsatility index actually increases. So these really basically demonstrate that you're improving forward left-sided flow while you're decreasing PAPI, and thus improving right heart support as well. The left atrial pressure dramatically decreases, especially in patients with severe acute mitral regurgitation, and the LV end diastolic pressure significantly decreases post-implant. So, and then finally, this absolute novel approach is doing a transcaval puncture. So down in the green, you can see that we're going into the right femoral vein, across the vena cava, and into the descending aorta. That's where the arterial cannula gets placed. And then on the right femoral vein, we're going across the septum, and we're draining. So we're getting both arterial and venous drainage, and then going back in. So you have biventricular support with an entirely venous drainage, which it basically takes care of any of the arterial complications that are so problematic with these complex patients. So these are some of the characteristic procedural outcomes, and I just want to focus on the bottom. There still is a problem with stroke, but a significant reduction in limb ischemia and a significant reduction in hemostatic problems and hemolysis, and very little hemolysis that occurs with these patients. So I'd conclude that LAVA ECMO provides biventricular support with a single circuit and use of large bore access with a low incidence direct complications. It's safe and feasible in experienced hands. Our cardiac surgical colleagues and our heart failure specialists are kind of in love with this approach because you get excellent hemodynamic benefit with unloading without the large bore access problems that occur. I should add that one of the major problems with the EcPella strategy is that you need a large bore arterial access for the EcPella, and a large bore arterial access for the ECMO arterial cannula, and so this really significantly increases the risk of vascular problems. We've been using it primarily in patients with severe valvular heart disease, and it's amazing how these patients are unloaded, and what we're doing now is we're unloading these acute AI shock patients for over a week to allow them to stabilize hemodynamically, improve renal function, and in all of these patients, they have not required intubation because LA pressures drop, so the oxygenation actually remains very well. So we improve hemodynamics, and we successfully bridge to other functions, in particular either VAD, heart transplant, or a placement of a TAVR valve for severe aortic insufficiency. Now, obviously, this is a debate because we don't really have formal randomized data, but at least in our pilot experience, and also it obviously is going to depend a great deal on institutional places. When I talk to folks that are used to doing like the 5-5, a surgeon comes in the cath lab, does a cut down very quick. In our institution, the patients need to go to the operating room to do that, and it just really is a complete struggle. So we've been really trying to figure out how to do away these biventricular support in the cath lab, and that's something that a single operator can do. So thank you very much for your attention.
So this is what's so beautiful in debates, because in debates you have the chance to listen to Bill O'Neill debate against EcPella. So, Bill, thank you very much for that. And I have to say, Dirk already, Westermann from Freiburg University, is going to present the other side. The side that actually a lot of us started doing almost more than a decade ago, the side of unloading utilization of ECMO and EcPella together. So, Dirk, kick it out.
Okay, sure, guys. So, Bill, thanks for the great talk. And I want to start the debate part, right? So, hopefully you're taking it okay, let's say. Can I have my slides, please? I think that was the first thing Bill tried to mess with my slides, but he didn't conclude. So. And obviously it's so easy, right? If you debate against lava, that's fascinating lava, right? It's interesting, it's hot, but it's very, very dangerous. So on the other side, the EcPella part, obviously everything is proven. There's nothing to debate, and we do have great data, and that's actually a depiction of what happens when you go into the red EcPella tent. You come out refreshed, so everything is set right. That's my conflict, and obviously when we talk about lava, when we talk about EcPella, we also need to be aware of, and everyone is, and many in this audience already know the data from this talk that is coming at the EC, the ECLS shock trial, I think very important for the whole for the whole field, and I think we need to develop VA-ECMO treatment further, whether it be lava or EcPella needs to be discussed, and obviously both can be utilized in different sets of patients. That will be shown in Atlanta from Jakob, and I think that's also very, very important for the field. So what is EcPella? What is the pathology? And obviously, the retrograde flow of the ECMO is a problem for the patient. It loads the ventricle. Bill just stated that, and we heard that a couple of talks before. And this might be the most feared complication, right? A thrombosis in the left ventricle or in the aortic root, or a combination of both. And when you have that problem, the patient is more or less dead. So additional treatment of a VA-ECMO patient with an EcPella device, an EcPella CP device, might be one way to counter that. So let's have a debate. First thing, obviously, is the access, right? And access for the EcPella part, for the Pella part, needs another large borehole access, but we have good and very known strategies to reduce the risk, right? So I think that is a doable approach in many, many centers, while going transeptal, Bill, is also, you see that's where he messed with my slides already. That would be a transeptal approach here, and I asked my EP guys in our hospital, guys, can you please send a complication after transeptal puncture? I need that for a debate. And everyone said, okay, we don't have these kind of complications. But actually, I got a couple of slides later from friends or colleagues, and this would have shown an aortic puncture during a transeptal approach. This can be really reduced by TE utilization or ICE utilization, just, Bill, as you showed, but it's still an approach that needs to have at least, say, experienced hands, right? And doing that under resuscitation isn't going to work out. So unfortunately, the case is also deleted here, so they used the older version of the talk. But actually, I went to Twitter, to X, and looked for some other EcPella cases, because I've shown all our EcPella cases already. So I went to the University of Georgia and found a very talented colleague, and he sent me all the slides, and I would have shown those. That's a very, very nice EcPella case. A patient with a non-ST elevation myocardial infarction coming in the ER with an ejection fraction of roughly 5%. They resuscitate, or there was need for resuscitation a couple of minutes later, and they put in an VA-ECMO in the ED. And Bill, I think you agree, going lava in the ED is really challenging. That's not the way to do that. And when they put in the VA-ECMO, they have, or they had sludge in the LV and also in the PA immediately. And then from the ED to the cath lab, they brought the patient under CPR to try to counter the loading of the ventricle and to prevent forming of a thrombus, and then went the EcPella way. And obviously, Bill, in a debate, patient turned to come out great and everything was good. So let's look for the EcPella data. And I think, Naveen, you're in the first row, and this comes from your lab. I think that's a very, very elegant paper in JAK-BTS, and it really shows the mechanisms behind unloading. And Bill, I agree, it might be very similar under the LAVA approach, but we just don't know. We had the pleasure to write the editorial for that and termed it Vent to Prevent, so I think that's so easy to remember, and that only Bill refers to EcPella, not to LAVA. I'm so sorry, because Naveen just gave the data. Does this work clinically? Yes, it works clinically, the EcPella approach. You have seen this probably. Under shock, the wedge curve on the left side is very high with a pressure around 40. When you introduce the ECMO, and that would have been the same patient I just showed you, or I would have liked to show you from Georgia, the wedge under ECMO tends to increase, and within minutes after introducing the EcPella device to a VA-ECMO patient, you can normalize the LV-EDP and reduce LV distension, so really counter the loading of the ECMO and get complete unloaded situation. You all know how hemodynamic looks, and I think we'll see more of those hemodynamic data later. Does this work from a clinical perspective? We are not very sure yet, but I'm pretty confident. You have seen this data, probably roughly 550 patients, and in red you see VA-ECMO patients, and blue ECMella or EcPella patients, so patients that are treated with the VA-ECMO and an EcPella during the same or on the same time to counter the loading effects, and you see a reduced 30-day mortality with that. Is there other data? There's plenty of data on the left side. So you see a meta-analysis from Russo. I think that was published 2019, so that's a couple of years ago. But it shows unloading the ventricle seems to be the way to go to reduce ECMO mortality, and that's probably something we'll learn after the ECC, right? On the right side, you see utilization of unloading in VA-ECMO-treated patients from the ELSO group, and I think that's really nice. Nearly 10,000 VA-ECMO patients, and you see that the unloading part in red is probably around 20%, and it has really risen in the last couple of years. And unloading, and only unloading with an EcPella device, not with an IBP device, interestingly enough, was associated with reduced mortality. Obviously, we need better data for that, and I'm very happy that we have started our Unload ECMO trial. It will have more than 10 European centers. We have 2 open now. Directly in September, we'll open 3 more centers. We have randomized the first 10 patients. And what do we want to test? We want to test prospectively and randomized whether addition of an EcPella device on top of a VA-ECMO reduces 30-day mortality. This is what we are going to do. We'll see the patient with severe cardiogenic shock due to severe left ventricular dysfunction, check inclusion, exclusion, obtain informed consent, which isn't easy, but there are models to do that. Then we'll have a one-to-one randomization. So the EcPella arm on the left side and the control VA arm on the right side. We'll have an interim analysis, and I think we'll have something around 300 patients for the study completion. And again, we already did include patients. We have more than 3 centers that will open in September. So I'm very happy to see this going relatively well. The interesting part of the Unload ECMO trial is actually that we do not focus solely on patients with army shock. And most data actually is only based on army shock, right? So we looked whether this unloading approach also works in non-army patients, and indeed it does. As you can see here, the cause of cardiogenic shock was not associated to the benefit from the EcPella approach, as you see here. And when you go to these subgroups, these are smaller subgroups then, but these are all non-ischemic parts, and they also seem to have a benefit from an unloading approach during the VA-ECMO treatment. And that's quite good for our study, that we can also include non-army patients. So I think and hope that will speed up randomization. This is the RCT for it, and again, we are already running it. And Bill, this would have been another picture of a fountain of youth where EcPella is stated in different forms. So just imagine this here, and I'm very happy to debate which patient might be best for which treatment option.
Bill?
So the attractiveness of the LAVA approach is certainly the apparent simplicity of the setup. A single pump, a single venous catheter, a single experienced person implanting it, which may also be a downside of the device. While on the other side, we have the advantage of the EcPella-based unloading, which has a forward flow in the left ventricle and in the ascending aorta, which may be an independent advantage. So we see the complexity of the EcPella approach, needing 2 consoles, 2 pumps, we double the expense of the device. So maybe we need another generation of approaches that combine the two strategies.
Well, I think that it really depends institutionally on where your group is, because there isn't a ton of randomized data. Right now, everybody's sort of struggling to try to figure out their techniques. In our institution, our surgeons are so swamped with heart transplant, with lung transplant, that they're always going out someplace to harvest lungs, and they're just not around, and they're not available to come in at 2 o'clock in the morning. And then if the patient comes in the midday, they've got to go to the operating room to get a 5.0 device implanted. So Mark can come into the cath lab and put a 5.5 device, and that might be the ultimate answer to all of these patients. But so in our institution, we get a lot of structural heart fiascos that are being transported, in particular acute AI from failing bioprosthetic valves. And we consider those an emergency. From the time we get a call, patient has AI to a TAVR, it's got to be within a week. Otherwise, those patients just absolutely crump. And in those particular patients, we've had absolutely nothing that can support these people other than LAVA-ECMO, because you can't put an EcPella in. It just doesn't really, across those failing leaflets, you make things a lot worse. So there are some circumstances where I think, if you ask me, okay, where is it that you absolutely need LAVA-ECMO? It's in acute AI, it's in VSD, and it works very effectively, and it may work with acute cardiogenic shock from severe acute mitral valve rupture. For these others, I think you have the time to put an EcPella, I'm not arguing against EcPella. I'm just saying that in some places it doesn't work, and it doesn't work in acute AI.
So Derek, Bill just mentioned you need to call a surgeon to put a 5.5. When you use EcPella as a EcPella, do we have to use the 5.5, or you can use less?
I think so first, I really want to stress what Bill just said. There are different types of patients in different needs of different devices or strategies. And the AR patient or the patient with a really high-grade stenosis might not be the EcPella case. Completely agreed. But I think when we see the big bulk of CS patients, EcPella might be a very good way. Why is that? Because you can put the VA-ECMO in, and even a couple of hours later, and we showed that in, I think, in Jack heart failure paper in the beginning of this year, when you implant the EcPella part of the EcPella strategy, within the first 4 hours, you still have a benefit for this. And this might also be interesting for centers that are bringing in patients. We did that in Hamburg. We are still doing that in Freiburg. Bring in or sending our perfusionists, so to call them, to other small hospitals, put them on VA-ECMO. They can't go the LAVA way there, and then we can add an EcPella when they are at our center. So I think that's a plus for the strategy. And the other part I want to mention is actually that when you have the EcPella in, you can utilize that for VA-ECMO weaning. And I think that's a big plus that is not there for the LAVA part, right? I think for the LAVA part, hemodynamically, it's beautiful when it's in and when everything has happened. But for the weaning part, the EcPella might be needed. For the first couple of days, you don't need a 5.5, but we switch to 5.5 in the EcPella process pretty often, and that's also part of our study. On the left side, you have the EcPella strategy, so that can be the CP in first, and then it can be upgraded to a 5.5, and we did that in Hamburg with Alex Bernhardt, wherever he's. I saw him pretty frequently, and doing that in Freiburg as well.
Yeah, the other thing I think that we have to emphasize is that both of these strategies still have a problem with bleeding and stroke. And in our center, we had in our series, we had a 10% rate of stroke. So it's a severe problem. I don't know exactly the reason why, whether the coagulopathy from the ECMO causes it or not, but that's a catastrophic complication. And that's we have to work on that to try to figure out how to minimize that risk. No, the question is the ASD, and we haven't really been closing those. We wait, and then if the patients have some shunting, we might bring them back later, but it doesn't really cause an acute hemodynamic problem. It's an 8 millimeter balloon that goes across, so the sheet size is about the same as you use for mitral clip or for any of the left mitral devices.
Christian?
Very important to give every patient the chance to receive immediately a 5.5 after ECMO insertion. So maybe not at 2 a.m. in the morning, but when you do this during the daytime and you have the time, let's say in the first 2 hours after ECMO implantation or first 4 hours to implant an EcPella, then you should generally consider whether the patient is a candidate for 5.5 support or not, because it also relates to the longer-term strategy, and it gives you the chance to reduce ECMO flows, which has advantages in terms of kidney function, hyperoxygenation, and so on.
Yeah, it's a matter of debate. I mean, I think that if the cardiologist had the ability to put in a 5.5, you would see 3 times the use that you do now. And I think the rate limiter is in each institution, you have to have one committed. If I had somebody at our place like Pedro Villablanca that was as passionate about the 5.5, we have a lot more 5.5 use. They won't put it in our cath lab. They have to go to the operating room. The operating rooms are swamped, and so they get done at the end of the day. And it's really a mess to try to get them in.
Irving?
Dr. O'Neill, the LA unloading physiologically compared to direct LV unloading, and conceptually we saw this, we're using tandem versus EcPella in certain VSD cases. Do you think the LV unloading is needed in certain LVs which are like too dilated because it's LV and diastolic, or are there cases in your experience where LA unloading was not enough and you saw the impact on the LV?
No, in the series, everybody that gets put on LAV-ECMO, we've been monitoring the LA pressures, and as soon as the flow starts, the LA pressure significantly drops. We've had like acute MR with V waves up to 70 that have gone down to like 0, or not 0, but 10 or 15 as soon as the ECMO gets put on. So I think that it provides sufficient unloading. The thing that's really kind of amazing is I don't know why, with wide open aortic insufficiency, that you're able to do that. You can do the same thing with a tandem heart when you put an LA device in. Even with acute AI, we've maintained patients for up to a week. So as long as the mitral valve is competent, I think that you're actually able to prevent LA distension, which is what causes all the problems with pulmonary edema and ARDS.
Jeff?
Just along those lines, do you have a sense of the partition of the flow between the LA and the RA? And also, you have a comparative data on LV dimensions with that versus, say, EcPella in terms of the change in the dimensions?
Yeah, no, not yet, Jeff. And I think that that's something that would be, again, we're just taking these off-the-shelf devices, and nobody knows how many of those holes should be on the LA side versus the RA side, right? And there's really no way of really trying to figure it out right now other than just sort of trial and error. We try to put the catheter in the left pulmonary artery and then pull it back a little bit so it's just sitting inside the upper part of the left atrium. But in terms of the percent saturation, for instance, no one has done that yet. This would require some interested company that would want to sort of develop that technique. Because there's a lot of iterations that could be made to optimize. For instance, if the LV is very sick and the RV is not that sick, then maybe you need less venous flow and more LA draining.
Dr. O'Neill, the LA unloading, is that a
An important differential aspect of the two strategies might be the hemocompatibility of what you're doing. So what we are seeing is if you are using ECMO and EcPella together, we see a lot of thrombocytopenia. We expect a lot of shredding of the von Willebrand factor with associated bleeding. On the other side, with the dual suction in the two atria, we have no flow in the left ventricle, expecting some thrombosis on the left ventricular wall, in particular in large myocardial infarctions. So what is your experience in these two regards of bleeding versus thrombosis?
I think it's difficult to see what actually attributes to which device in view of thrombocytopenia in EcPella patients, right? So it would be interesting to compare that to the LAVA patients, although they are different patients. And you will also see that in your LAVA patients, I guess, because the ECMO device is also known to do that. I think very important is that you look for the flow level of the EcPella, not to put it too high. In the EcPella approach, you really just need it to be P2, P3. It's only there to emptying the LV in the beginning. And then it takes over the role as a mechanical circulatory support device. But initially, it's really only like stopping the loading of the LV, and then we don't see too many problems with blood values.
Yeah, I think you're absolutely right in terms of the clot forming in the LV and in the ascending aorta, and we've seen that in patients that are just on pure ECMO. If the heart doesn't contract, you're going to get a huge clot regardless of the level of anticoagulation, and worse, you can get clot formation that basically totally occludes the proximal part of the aorta, so there's no coronary blood flow, and there's just no way to get around that. That's really kind of one of the fiascos that happens with pure ECMO.
Then
That actually was my question, Bill, about LAVA. LAVA will, effectively unload the pulmonary venous system, unload the LV, but that means that the LV can generate less pressure because of lower preload. Have you seen more aortic valve closure and aortic root thrombus? For the duration for people on long-term support, they've been primarily the acute AI, and I think there's actually enough blood flow sort of coming through to prevent clot formation. For sure, but that's something to be concerned about.
But if the aortic valve is competent, I think that's a real problem.
Yeah, that's something to be concerned about.
So there's a question in the back.
Just to make Bill, thank you, a pitch for the surgeons. I think that the importance of both, it's clear. Have you used it with acute MIs with LV thrombus, the LAVA?
We have not yet.
But I think that would be a wonderful indication, right? If you already see LV thrombus, it's at least difficult to say at least to go the EcPella way, right? And I think we did one case in Hamburg a couple of years ago directly for that, because that one came in late with a subacute STEMI and already had an LV thrombus, and that's when we used the concept behind that.
What about duration of support? You obviously can't mobilize these patients, correct?
Pardon?
You obviously can't mobilize the LAVA patients. I mean, that's the benefit of the 5.5 upgrade with the EcPella. What's the duration of support with the LAVA patients?
We've had them up to 2 weeks, and they flat. But they're also extubated. That's the other kind of hidden advantage, is that by unloading them, the LA pressure drops, and then they don't really develop ARDS.
So, guys, this is still a debate, and we need to decide what is actually, who is the winner. So there is the online QA that for the unload of ECMO trial, what what stage patient are being included?
Yeah, I think that's important. So we didn't focus on SKY. The actually starting point for the unload ECMO trial is a doctor saying this patient needs to be on a VA-ECMO, and the lactate needs to be above 5. So that's also differentiated from the ECLS shock trial, I think. So we didn't go for SKY shock classes. But this is pretty much D and E, right?
So now we're going to do the first. We're going to do it in clapping because everybody deserves clapping here. And the first one is LAVA, 1 device, not 2 devices. Direct unloading of the left atrium, very good in valvular condition, maybe in acute MI in a setting of that. Or we're going to go, the second time we're going to clap is 2 devices, some recovery option, that we are going to do. So are we going to do direct unloading of the left atrium or going to do venting? So direct unloading first. Whoever want to clap? And of course, EcPella. Who want to clap? And for our two amazing debaters, thank you very much for coming.